So I just wanted to run through this more actually towards the end of the few slides to think about how we get people to transplant. So I suppose the substance of the presentation or the discussion is actually how should we think about getting people to transplant. We could, of course, endlessly discuss about when they come to transplant, how we do the transplant and maintenance, but that's not what I want to talk about. And I wonder whether we're being rather sclerotic in our upfront management of patients who are allomandatory. So, well, we know that we need to take a lot of people to transplant. We can do that more easily. And we know this is wonderful data from the HOVON, a 70% reduction in relapse risk in the patients who do get to transplant in CR1. So this is a really powerful weapon. And this is how we come to decide which patients should be coming to transplant. This much we know. We also know that we're getting better at transplanting. I wanted to draw your attention to this New England Journal paper from a month ago from the US CTN, showing that there are strategies to reduce the risk of acute and chronic GVHD. Post-transplant cyclophosphamide is one. This is a great paper, but in some ways it's a flawed paper because the control arm doesn't use ATG. And of course, half the world uses ATG. So the currently rapidly recruiting UK impact study, MOTD, is got a control arm with ATG. And I think that will also be a practice informing study, but no doubt that this is informing practice in a lot of the US. So pretty exciting. I think it's also really exciting. This is Bronwyn Shaw's phase 1/2 data in JCO about a year ago. The ACCESS trial, which is looking at the ability of post-transplant Cy to allow the safe use of multiply mismatched unrelated donors. Building on this data, I think is also potentially transformative in terms of how we think about taking patients from all ethnic groups to transplant, and perhaps doesn't get as much attention as it should. This remains a real ethical issue for us, and I think Fromin should be congratulated on this study, which is now 2/3 way through accrual. So I think my challenge would be around how we optimize transplant outcomes, not so much focusing for this discussion on how you do the transplant, but actually whether our conventional intensive induction regimens are the smartest way to get people to transplant. So if we think about what we have at the moment as standard tools, well, in high-risk disease, adverse karyotype P53, it's pretty lousy. The CR rates are no more than 50%. There's a lot of MRD positivity, and we underestimate, I think, the impact of the toxicity of the induction regimen on subsequent post-transplant outcome. And we need to be thoughtful also that the toxicity in this population of induction per se stops quite a lot of people getting to transplant because they die from the induction. So what in an ideal world should we be looking for if we wanted to devise our perfect induction strategy? Well, it should have minimal day 60 treatment-related mortality. It should give you a much better CR rate than we have at the moment. It should give you a nice rate of MRD negativity, and it should be well tolerated. And that means really, I think, us beginning to think in a different way and less of this sort of Manichaean, how do you do the transplant, how do you do induction, but actually trying to integrate the strategy and thinking about the first dose of induction therapy the patient gets is a critical predictor of how the transplant's going to go. And this is Swedish data, wonderful Swedish data, just speaking to the point of low CR rate and high toxicity of induction. And this is Jeff's data, which I think is, really so informative. Jeff may want to comment on this, but as I read it, most of the benefit of CPX was in the people who got to transplant, although it remains a bit elusive. Jeff again can update us on whether that was because there was a better MRD status pre-transplant or less transplant-related mortality. My interpretation of the slightly elliptical comments about this is it was the latter. But nonetheless, it does show what you do in induction profoundly impacts transplant outcome. And I think this is really pivotal data in this space and encourages us to think about different induction strategies. You'll get where I'm going. So we now have triplets that are in phase 1/2 studies clearly showing promise. In the interest of speed, we're aware of the Veneza Magro data, high CR/CR rates, well tolerated. We'll have to see where we go with Enhanced 3. But on the basis of that, the UK is still planning in high-risk, fit, allo-mandatory adults to randomize them to either Vyxeos or FLAG-IDA compared with this triplet. I think this is a little bit like Amir Farthi's study, which I know less about, and maybe Gail can update us on. Again, I think a really important and beautiful study. Same idea. So I would be, in closing, I would be suggesting that the emergence either of the Veneza doublet or triplets using either mutation agnostic therapies like a CD123 targeting agent or magrolimab, or in the FLT3 mutated populations like gilteritinib, a targeted therapy, have every potential to displace standard induction chemotherapy. And I think this is one of the most exciting areas for randomized trials, because I think the wins are multiple for such an experimental regimen. Let's just say the CR rate was the same. It could still win, even if it didn't give you a higher CR rate, by having a better CR MRD negativity. It could still win because more people get to transplant. It could still win because transplant-related mortality is reduced. So I guess my conclusion to this would be that the emergent triplet data in small phase 1/2 cohorts we should be aiming to replicate that in selected patient populations who don't do well at the moment with standard induction regimens in randomized trials. So I would be fascinated by comments from colleagues, and I perhaps just ask Jeff maybe to comment, and I'd really be super interested in Roland's take on this, and then maybe Gail, then we open it up and see what people think. Would that be okay? Jeff?
I think you said it really well, Charlie. And I think, in my mind, a major question is, again, many roads can lead to remission, but then what is the best path to get a patient to a long-term remission or cure thereafter? And there are many factors that may affect that, including fitness following therapy and ability to go through additional therapy, the level of remission. I think, you asked me to comment on our data from CPX, and I don't have a great answer. I think the data do point in the direction more of decreased transplant-related mortality than actual efficacy of, treatment against the primary disease. But I think it illustrates the fact that you can achieve different outcomes post-remission, depending on the therapy received, even if we don't understand what those specific variables are yet. I guess I think that one area that we might need to focus on is how do we better bridge patients to, or is there a need to bridge patients to a transplant based therapy? And do we need to look at MRD directed therapy against non-MRD directed therapy in, for example, the MRD positive setting post remission? If you have a high risk patient that doesn't achieve an MRD positive result or MRD negative result, do you take them? Should we be looking to try to intensify treatment in a way that improves their biological disease status, that then allows them to potentially undergo a more successful transplant? Or do we not do that because of concerns of inducing more complications and toxicities? So in my mind, there's still that big gap between there's still a big gap in knowledge about how do we optimize a patient's status before going to a transplant that we have not yet really uncovered, and that I think studies need to focus on. because clearly there are opportunities to improve outcomes based on different therapeutic approaches that are given initially. So
great. Thanks, Jim. Maybe Roland and then Jorge Sierra from Barcelona will give some wise transplant thoughts. Roland.
No, I mean, I think you sort of summarized it, right? I mean, one of the questions is whether the lower intensity treatments lead to similar relapse rates after transplant if they're in the same type of remission, right? Let's say MRD negative remission, whether they have less non-relapse mortality because maybe they're less beaten up, as you mentioned. But of course, it's transplant that people are all selected, right? So you have to kind of go back to the very start. And yeah, if you're getting the MRD negative patients, for example, to have same relapse rates as Farhad's paper might suggest, and maybe similar reduced non-relapse mortality, if you're getting 20% of people less to transplant because they have less MRD or lower MRD negative response rates, the equation gets a lot more complicated, and it needs a data set that doesn't just include the transplant patients, because you're selecting people on it, right? So it gets really tricky.
But we could still, if we started the clock on day 0, we could still.
Yeah, you really have to start on time 0 on this one. Yeah.
Okay.
Yes. So let's see. Our backbone remains intensive chemotherapy to achieve the remission when we have the intention to perform an allogenic transplant. But the number of patients who are considered unfit for chemotherapy and receive venetoclax azacitidine, that after treating the leukemia become eligible for a reduced intensity transplant is increasing. So I think that the two alternatives are good options to bridge to a transplant. Intensive chemotherapy for patients considered initially fit, and venetoclax azacitidine for those who are not fit at the moment they have florid leukemia, but then may become fit for a reduced intensity transplant after achieving a remission. And the preliminary data we have of transplants after CPX or after venetoclax azacitidine, although they need to be more mature, are very encouraging, with survival of around above 60%. So I think that the two options are good, and that, of course, the best strategy, even in younger patients, has to be tested in randomized trials. So I know that there is one in the US which is ongoing, and we are trying to convince AbbVie to perform another trial in Europe. So I think that the definite answer will come from the results of these randomized trials.
Great, thanks. Okay, I was going to turn it back to Gail now, actually, our chair, for perhaps some final comments. Gail.
So I was actually considering writing a lecture on this topic. I may yet at one of the upcoming meetings, with a title that sounds something like, is less more or is more more? Or, something, like is on the figuring out whether, if you can deliver intensive therapy and cure the disease, I think we want that. So if transplant is better and induction mortality is going down, and if we knew that you could get somebody into MRD negative remission with a better induction strategy and then get them safely through a transplant, and if they would be done, I think that would be good, and we would want that, because I do think that ongoing maintenance therapy, here I am, I do a lot of maintenance. I love the idea of being able to keep AML away, and we do this for a lot of patients, but it's no fun to take a lot of pills all the time, forever and ever. So I don't think that we should move away from working really hard until we're all in rocking chairs to cure the disease. And if you can actually cure the disease, we should do that for whoever is curable. That said, there are plenty of patients where no matter what, they're just not going to be transplantable. And for those patients, I think you have to take a very good look at the, what's going to happen in 2 years. We have to stop telling patients, who are more frail or really advanced age into their 80s and beyond. I think trying to transplant absolutely everybody probably won't ever make sense, and trying to get really good 2 to 5 years survival with as little therapy as possible is a really good goal there. But I do think that we need to still try to cure the disease and not have the assumption that we just put everybody on ongoing post-remission, whether it's post-chemotherapy, post-consolidation, post-transplant maintenance forever. It's if we have to, we will. But if there could be curative, definitive therapy where somebody is truly done with the disease, I think we should strive for that.
I'm not completely agree with you, Gail, because if you compare, for example, cardiovascular disease, when you have a myocardial infarction, 20 years ago, your second myocardial infarction was within 1 year. Now we can prevent a second infarction for 20 years, but you have to take pills, a beta blocker, a statin, an anticoagulant for many, many years. And that keeps you healthy, I should say. And also those drugs are not without side effects. But I agree with you that if there is a curative possibility, that we have to take it. But we also have to take into account that despite the fact that we better prevent and treat our graft-versus-host disease, chronic graft-versus-host disease is still a very, very bad disease for our patients. And still 1 in 10 patients suffer such a disease after an allogenic stem cell transplantation. So every attempt to improve to prevent that would be my favorite.
And that's, I think, why the US CTN study is so exciting, that we will be getting better at both access to transplant and reducing transplant toxicity. And I personally think the danger is that we're wedded to very old-fashioned ways of getting people to their only curative therapy, which is true for allomandatory fit adults. And it's actually very exciting to think about how you take these triplets or doublets, actually in the context of a randomized trial, just as Roland said, starting the clock at day 0 and seeing whether that actually transforms the outcome of transplant. So thanks for listening, guys. I'll hand back to Gail.
Yeah, can I just make one more comment? So just
sorry, Jeff.
Sorry. No, that's fine. No, I just think another sort of on the opposite end of the spectrum, what you said, we should be asking, when is enough enough? And that the ability to define therapeutic and therapy endpoints is going to be really important. Like, we don't know that you have to give HMA-VEN or maintenance therapy forever. There's no proof that giving 6 months is worse than giving 12 months or 24 months. And we don't know anything about the dynamics of the disease that, could indicate the potential for successful retreatment. Like we do it in CML, we clear, I know it's a different disease, of course, but we clear MRD negativity, or we achieve MRD negativity. We stop treatment, disease comes back, we start treatment, it works again. We should be thinking about, can we apply the same concept to AML that may not result in a cure, but maybe less resistance that develops over time, and the ability to have longer off treatment times for patients that are going through this. So I think you can think about it in terms of curing, getting people to cure, but also for those maybe not curable, when is enough enough?